Thank you. What we would like to do today is talk about the impact of accreditation on clinical outcomes. We heard from our prior speaker on the fact that outcomes are important. Everything in our life is important. We're looking for some kind of outcome. But when you think about this, and you think about it from an accreditation point of view, I'm going to take you through a journey on JCI, who've been doing outcomes for quite a number of years. First of all, if you think about JCI, we're not as 100 years that have been in accreditation. I don't know any accrediting body that has been around for 100 years. I feel like I've been around for 100 years, but not that much with all my traveling. But if you think about JCI, JCI currently is in 70 countries plus and constantly growing. It has about 108 accredited organizations, excluding those that we have domestically. But the fact is, though, accreditation is what? It's just basically something that you're going to use some tools to figure out how you're doing it. Being accredited doesn't make you a safer organization. It makes you a wiser organization because you're going to have data that you could use to make some kind of decisions. So the question now is, for us, is what type of accreditation can have impact? You want some type of impact as a patient, as a clinician, as an investor, etc. Will accreditation make healthcare safer, and will have it an impact? The fact is, it can only be safer if you use the information you gather from data. Many times, and I'm in a different hospital usually every week of the year. Last year I was only home 60 days, so I'm in some place. And usually I go to many hospitals. You have a lot of indicators. You have a lot of things you measure. But I can't say you're safer because I see more injuries occurring because people don't use the data. So if you think about that, I use the Swiss cheese model, which is a cumulative effect. If you think about any injury that occurs, it doesn't just occur from one person, from a physician, from a clinician, etc. Rather, it basically has multiple effects and multiple layers. Sometimes it's the environment where we try to do things in. Sometimes it's the medical equipment that we use in order to make a diagnosis or to make a treatment. Sometimes it's basically the organizational culture, because many times we as individuals in healthcare keep our mistakes to ourselves. We don't want to share it. We're afraid people are going to think less of us than basically saying, maybe it wasn't that, maybe it was the way we structured. It also could be our clinical guidelines and policies. We have excellent clinical guidelines and policies, except we don't follow them because we don't want to. We find out that your policies are usually could put you to sleep. Most of your policies are too long, too verbose, and no one reads them. But then you've got the issue where you've got teams and individuals. As clinicians, we're taught to work as an individual. We're licensed as an individual. We're assessed as an individual. But when we're in a hospital, we have to work as a team, and many of us don't like working as a team. So all these things will basically cause you to have what we call an adverse event. Now, what does accreditation do? Accreditation will give you steps or blockages. Because of the standards, because of the processes, because what we want you to look at, it will basically put little barriers or layers of defense to say, let's stop something, take some time out to see if we could improve. This is what most of us do not do. Most of us use the accreditation, as was said, every 3 years, every 4 years, versus on a day-to-day basis. If you use the accreditation model, the concepts, the tools, the designs that could make you safer, chances are you could stop a hazard because you're going to stop it at a point where it starts, or you're going to basically address it easier. So if you think about the evolution of accreditation, accreditation is only a theory or a philosophy, and it all has to deal with safety. That's the goal of accreditation. Quality is an outcome, but safety is the first process. Then you have to think about, can you say in your hospital that you work today, where you're not at, now that you're not there, can you say you have a culture of safety? Is everything you've put in your policy, is it being done on a regular basis by every staff, from your transporters to your nurses, to your medical staff, to your leaders? If you can say I could sleep easy at night because I know everything is being done, you are living in a dream. You are not living in your real world, because that does not happen. Rather, we look sometimes at accreditation, as my colleagues have said, on legislation, but accreditation is a group of thoughts or standards which will basically give you a process. It will look at the process, how you're delivering of care. It will also include certain tools, like was talked about. Some people will use Lean, Six Sigma. You use the Plan, Do, Check, Act process in order to basically think about how things are going to be done. However, those tools have been new in the last 20 years to healthcare. However, business has been using them for quite a while. If you really want to become a useful accreditation process, you've got to move to what we call a high reliable organization. Something that your power companies, your nuclear power plants, your airlines have moved to. Healthcare is always a little further behind. So what you have to think about is, if we take this in a stepping process, the first step of accreditation should be, if I go for any kind of accreditation, ISQA, local accreditation, JCI, Canadian, whatever you want to use, is there a focus that everybody is going to focus on safety, an impact of safety? If you cannot talk about that, or if your leaders do not propose that, chances are it's not going to happen. Now, JCI has taken a different approach. JCI has made a whole group of what we call international patient safety goals across the organization. And these goals basically talk about where we see the biggest harm occurring to both patients and staff. Have you identified the right patient before you do something to me? Have you improved your communication in either the area of telephone verbal orders, reporting of clinical test results for both diagnostic for lab and radiology? Have you handed over communication to make sure where you're dealing with me and someone else takes over? Do you expect the patient who is sedated to basically say they had the medication or what the reaction was? Do you improve your issue of high alert medications? Do you have something on ensuring safe surgery? Do you even take a time out before you cut off the wrong limb or before you work on the wrong eye? Do you basically have something to deal with hand hygiene and spreading of infections? And do we look at falls? These basic topics have been around since the 1950s, when the American College of Surgeons, American College of Physicians, and the American College of Hospital Administrators all got together. And this was less than 25 years ago that every hospital in the United States, of the 100 hospitals that they visited, failed. We're still failing them today. Yet we're the most highly educated service providers around the globe. We have the training, we have the education, but we don't do it because we're going to do it our own way. If you think about that, if you think about JCI standards or Joint Commission standards, we have a section in our area called QPS, or Quality and Patient Safety. The whole process there looks at management. It looks at staff, because without staff, you can't treat patients. It also looks to see, have you done any kind of analysis? Have you done anything about variations between your analysis? Not everything is wrong, but you have to know where there's variations among departments. You have to also see, is there any near miss? Many times I will ask people when I'm at a hospital, so Tell me about your near misses. How many medication reactions or near misses do you have? They'll say 3. I say 3 a minute? No, 3 for the whole year. But you gave out close to 2 million medications. That's impossible. People don't report what they need. So we have now, in the 6th edition, pushed you now past the quality, past the idea to say what you need to do now is you have to identify risk. If you don't identify risk with risk tools, you have stuck yourself 30 years behind the quality stage. It has to basically look at risk in order to figure out what's going on. You have to also then get some commitment from leadership. If you don't have commitment from the top of leaders, you will go nowhere. Your staff will say, Tom's not concerned about it this week, so who cares? I'm more concerned about just making sure I get things done. You have to basically make sure that the leaders have priorities. Priorities mean that it has to be done. What's that for? You don't want that for a leader? I don't listen to leaders like that, okay? I'll try to do as quick as I can. You also have to do, if you have anything, you have to come up with some solutions. Leaders have to decide what the priorities are and what solutions they're going to choose in order to get them involved. But if you're going to do any change, you're going to have patient involvement in their care. So what you need to think about is if you're going to reduce medical errors and self-patient harm events, you've got to have some basic measures that you have to deal with. And your measures then have to basically promote quality structure. If you think about some of the places we've been to, like the medical center in Israel, the hospital-wide priorities chosen by senior leaderships were based on strategic goals, which is what your measures have to be on. If they're not going to link to your strategic goals that you have on a yearly basis for your budget, nothing's going to happen. You also have to look at performance. But if you think about that Swiss cheese model, and you think about the wrong patient being typed in cross-mass for a blood project, you'll see that even a very experienced nurse who draws the blood, but because she was doing multiple things at the same time, could basically have multiple patients in the same room. Someone else labeled it, which eventually caused a basic injury to a patient and maybe injury to a staff. And that means you have to look at the various things. You've got to drill it down. This is quality. This is what accreditation makes you do. The similar thing would have to do if you had to deal with handovers. You have a patient being transported by a transporter, but never realized the fact that the oxygen was gone. And this was an elderly patient who was confused and was oxygen dependent, however, had a fatal result because no one basically re-looked at his oxygen. These are actual events that have occurred in many of the hospitals that I visited. Another one that you'll see is, here again is a very experienced 20-year veteran, competent pharmacy tech. However, they were working with the NICU. You had a fragile, sick newborn, high-risk population, and basically the medication that the nurse gave was a double dose, and this storage of the medication was so small you couldn't even read it, which caused a death in the child. And we have so far multiple children get almost 100 times too much heparin, and we have 3 fatal fatalities. How many times do I go to your crash carts in your area, your emergency carts? They're all filled with adult medication, but yet there's no kind of medication dosing for peds. Similar things would go for your other international safety goals. If we keep on going through this, your slides will all be available to you. I just want to get to another one. Some techniques you could think about in order to improve is basically have a patient safety awareness week where the center of your quality program is going to be used involving the patient family. If you don't involve me, chances are you're not going to have it. Patient engagement is going to be a key part in any accreditation. We've included that in JCI. accreditation, because we will interview the family and the patient, because they're the ones who are there receiving care. They're the best ones to tell you what's going on, not your silent shoppers that sometimes will be able to deal with and sometimes will not. So you have to think about this. Tell me and I forget. Teach me and I remember. Involve me and I'll learn. If you use this model for not only your staff, but also your patients, you will provide quality care, you will provide safe care, because I as a patient is going to ask for it. Then there's some issues that you have to do some monitoring. But if you're going to think about this, a culture of change will basically impact accreditation. That's what accreditation is going to do. It's not a peer review. Accreditation has never been and should never be a peer review. I cannot peer review you on one incident. You have to look to see how you're going to change your culture. If you think about that, you need to raise your quality concept, your quality or your QI structure, to get it away from the flow of information just to committees, to department heads, but rather restructure it where you have quality improvement sections, risk management, and customer satisfaction. This is quality of today. This was quality 50 years ago. It's time to change to say how you're going to improve and show risk management and customer satisfaction. If you think about those processes, places like hospitals in Buenos Aires try to improve effective communication. Why? Because every error that occurs of injury, if you drill down far enough, it's going to be lack of communication. Someone didn't listen, someone didn't talk about it. And those are things you need to think about as you move your issue to define the problem, identify, prioritize, improve, and measure. Your basic PDA cycle. So if you think about this, think about how you structure yourself. Many times I'll go to organizations and you haven't improved your bundling because it's all over the place. Keep it simple, keep it together, and you're going to get it much safer. If you think about that, do some Lean Sigma, Six Sigma, or the safer processes. Make sure you could basically show yourself how you could reorganize and save yourself on space, because hospitals don't have enough of space. If you think about that, if you have quality and you have good quality data, it will give you a return on investment. A return on investment means the fact that a cost effectiveness should improve your length of stay, and that's what quality data should do. If you think about this, if you use quality data properly, it should reduce unnecessary hospital stays and prevent infections. Many of us like to build more hospitals. We don't need more hospitals. We need a better way of running a hospital. More beds doesn't mean a better care. It just means more infection and longer issues. You've got to have shorter length of stays. Because of that, you need to think about your length of stays. Sometimes I see it as 7 days. It needs to start cutting down. Your turnover rate for many of your staff is because of the fact that I'm dealing with the same patients, nothing's new, nothing's different. You need to change it, and if you change it far enough, we should be able to change the average length of stays down to maybe 4%, which is maybe the average now, unless I'm really acutely ill. And then you should get down to 3.2 if you're really doing it right and you're doing quality right. You should see then a savings. So what I'm asking you now to do with your quality is to achieve what we're calling zero harm or zero defect. Can your quality data, can any of the data you're collecting today or your accreditation you're using today, can it bring you down to what we're calling zero harm? Is there one measure that you could show me that you have done and you've cut down harm at all? If you can't, then your measures are useless and nothing is going to work. You need then to basically think about artificial intelligence. Even though we don't like it, we have to basically start using what's available to us that we haven't done before. So again, thank you, and hopefully I went over the bell, but that's life, okay?